Okay, Mary, do we have a quorum?
Yes, we have a quorum.
And, Ed, if you would lead the pledge, and Ben, if you would pray for us.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Lord Jesus, I thank you so much for everything that we are blessed with. I thank you for the place that we live, and I thank you for this hospital. And I thank you for everyone who works here and puts in time and effort. And ask that you be with this meeting. Please bless us as we come together and make decisions. Give us wisdom, give us strength, and be with all the employees and all the work they're doing right now. In the name I pray, in the Lord Jesus Christ. Amen.
Have any visitor comments?
You might want to say it loud, a little bit louder.
Do we have any visitor comments?
Do we have any visitors?
Okay, whoever that is.
And all of them, they're technically visitors.
What kind of visitors?
Informed visitors.
Okay, do we, have everybody looked at the minutes? Do you have any changes or additions, or do we need to approve them?
Madam Chair, I move that we approve the minutes of July 17th and August 5th.
Do we have a second? Any comments, any discussion? All those in favor of approving the minutes, say aye. Aye. All those opposed, say. Okay. We've approved the minutes. Do we have
And you
any?
abstained, right? You abstained, did you abstain? You abstained, because they weren't here.
Because they weren't here.
We just want to record it, that's all. Okay.
And do we have any addition or changes to the agenda?
I have one request, and that request is that we have the company from the Revenue Cycle Management Company do an initial assessment piece, and they're on my CEO report, but if we could just move them up to wherever you'd like to put them, then they can come in. I think you have them for about 6 o'clock, right?
Yeah, I asked her to log in about 5:45.
Quarter to 6, so
Just to be a little early.
just if we can do that when they arrive.
So we'll try to do that at 5:45 wherever we are.
Okay.
Or as soon as we can stop at 5:45.
Okay.
Or
Thank you.
5:45.
I appreciate it.
How do we do that as far as the agenda goes? Does it matter?
It probably doesn't really matter, I just am requesting it, so it was hard to know exactly what time.
Right.
If we didn't know that.
It's on my page.
What's it?
I think we have a lower employee, can we move? I don't see the introduction.
Oh, for mine, that's in my CEO report.
Does Trish want to say something?
Well, she can, do you want to say, you want to go ahead first so that you can leave before we get real long and windy around here? Oh, no, she's fine waiting.
Okay, that's what I was concerned about.
Thank you for asking.
Okay. So anything else as far as the agenda goes? Are we good? Okay, I would entertain a motion to approve the agenda.
Madam Chair, I so move.
I'll second that.
Okay. All those in favor of approving the agenda, say aye.
Aye.
All those opposed, nay. Okay, the agenda is passed. Okay, so now we have our 2 new board members, Dottie and Willie. We are happy to have you here. Thank you. Yes, welcome aboard. Please feel free to ask questions. All of us, any of us, you know, and I think both of you have my phone number. Call.
Yeah, I probably really should give you my phone number so you guys have it. So, I can send it to her. Okay. She'll send it to you guys. It's not a secret, I have it out and everything.
And I thought it might be nice. Yeah, anyway, okay.
What is that? That's the person. That's,
Okay. So does that mean that we should?
that's up to you, but, I think that she's only gonna be, what, 10, 15 minutes or so? Yeah. So you wanna do that? Sure. Yeah, I wanna do that. You guys are okay with that, right? They're probably wondering too, so, yeah, okay. Okay, you wanna introduce her and stuff, Tish? Yep. Patty? Can you hear me?
Hi everyone.
Hi, Patty. Is your camera on?
It is, and it says it's blurring my background, but it's on, but for some reason it's not showing me. Is there something on your end that might be blocking it?
What's the part that says share? Share screen. Or control. There you go, share. Share the screen. She'll have to do share screen first and then you'll have to approve it, I think.
Yeah, I'm trying to share video, so not my actual screen, it should be the video. Let's see what's going on. Why is it not working?
It's a share,
Share, go share, right there. And then there's a.
video sharing, and she can see it how she's got the black
Just hit share.
Hold on, it was an user error. I just had a new computer recently, so it was hidden in my screen. So I'm here. Hello, everyone.
Hi, Patty. This is our board. I don't know if you, anyway, this is all of our boards. This is Patty. Patty is the owner, one of the owners of Nova Revenue Group. And she's here to give us a presentation, high-level presentation for what they found and what they can do.
Yeah, exactly. Thank you, Tish, for that introduction. So I'm Patricia Chua. I'm the COO of Nova Revenue Group. So we are an end-to-end revenue cycle company. We deal with rural healthcare hospitals, acute care hospitals, clinics, RHCs, freestanding clinics, SNFs, the whole gamut. We've done many, many years of rescuing hospitals that are struggling. And that's kind of been our passion, is helping out these little rural hospitals, because we know how difficult it can be. So we're here to kind of provide some ideas of where we can help you guys. As you know, we did a revenue cycle assessment. We've been working on it actually for the last probably six weeks or so, 6 to 8 weeks. So we kind of really dug into your data. We did interview your key stakeholders, your people who are running your registration, your billing, your coding. We talked to most of the people that are involved in all of that billing, so we kind of got a good handle. We also pulled reports out of Epic. So I have Albert, he's an expert in Epic. He's an analyst, worked for many years in Epic, and knows how to pull out those important reports that Tish needs to show, how much money you guys are losing and all that. So basically, let me just jump into what we found. When we went in and we did the assessment, we pulled the reports out of Epic, and we noticed that, we noticed 3 main areas where you guys need improvement. So one was your self-pay. 30 to 40% of your outstanding balances are patients paying out of pocket, and almost half of this is old, and it's unlikely to be collected. So that's one of the areas that we identified. We also looked at your denials, so you have a lot of preventable denials. I think it was about 15% of your claims are being denied currently. Most of the reasons why are for credentialing issues, there's missing information on the claims, there's some coding issues going on. And I have a report that I was given to Tish that kind of goes a little bit deeper, but I'm just kind of giving a higher level overview for you now. The third thing is your billing setup. So we noticed that we looked at EKGs as an example, and your clinic visits that are being billed incorrectly. It looks like you guys are set up as you guys are billing as a rural healthcare and RHC. A or you guys are actually a provider-based clinic. So setting you up correctly to bill the correct way with Medicare is crucial. That's why a lot of those EKGs are being denied, is because they're being billed incorrectly. So looking at the numbers, we looked at your hospital billing, we looked at your professional billing side. So when we pulled our data, we looked at July, we looked at the AR about that time was about 3 million. And the big thing there is that we found that about 23% of your AR is older than 90 days. So as you know, as we get longer delayed days, that's harder to collect on those claims. So we really want to focus on those claims that are getting to the timely filing and get that stuff rebilled if we can. We also looked at professional billing. That was about $568K. And there's still a lot in self-pay for them as well. I think that's the biggest financial risk, is that self-pay. Finding someone to help you with that, and we can do that as well, is just prioritize, give you some ideas of how you can get that alleviated. We can help with that. Denials, you know, they cost hundreds of thousands and lost money each year, so we want to make sure that we're addressing these consistently. That's one thing that we found, is that we would see you guys have denial work list in Epic, and nobody had been working on for a couple months. Some are pretty consistent, but then we found some where where nobody has touched any of the claims, hasn't looked at the Medicare denials. So us getting in there and digging in and really looking at the denials and rebuilding what we can, that's kind of what our main focus is.
This place is full of love. You can tell the people that like to be with old people, because they really take care of you good and are very kind.
Twice a day, every day, the activities people have, an organized activity that's always interesting.
Everybody loves to play bingo. We play it 3 times a week here. We also have ceramics that you can paint. Really pleasant to live here. It's a good place to be.
The good thing is, you know, you guys do have a good clean claim rate. It looks like it was about 70%. So that means most of your claims are going out pretty clean, which is good. And all your staff is wonderful. When we talk to them, they're so dedicated to the community, to the hospital, want to do what's right. So I think just us being there and kind of shadowing them and kind of leading in the right direction is something that they're lacking. A lot of them have been here for years, and you know, they've been doing things a certain way for such a long time that they're having trouble adjusting to some of the recommendations we're making. So we know that's kind of a cultural thing as well, bringing us in. And some people, you know, they don't like that. They're small, they're in a little community, so sometimes we're seen as a threat. But we like to make it, you know, pretty clear that we're there to help you guys. That's our passion, is to get these small little hospitals out of these financial crises that you guys are going in, especially with, you know, the big beautiful bill that's coming. Rural hospitals we're gonna see how that's gonna affect us kind of in the coming months. So some quick points that we feel that we can help with is, you know, looking at your self-pay, seeing if any that can actually be billed to insurance. Sometimes they're just classified incorrectly. Looking at your provider enrollments, that's a big one. A lot of denials are due to providers not being credentialed correctly. And then looking at your clinic billing and getting that situated, signing those up to be billed the correct way. Also centralizing your billing processes. Right now, a lot of different people are working on the same thing, touching the same plans, but stuff's not being resolved. It's kind of going around and around. So standardizing your workflows, monitoring your key metrics. That's another big one. There's really no key metrics that we were provided from your team of, you know, this is what we're monitoring. This is how much outstanding coding claims there is. We didn't get anything like that, so making sure you guys have some some key monitoring that you guys are doing, you know, holding your staff accountable, that's another big one. So how we could help, like I said, you know, we don't just hand over a report, we work side by side with your team. And, you know, that's another thing I talked to Trish about it. Do you feel that your team is capable of conforming to some of these suggestions? You know, we do full outsourcing as well, the building department, so we have a team of about 10 to 15 folks who specialize in rural healthcare and critical access hospitals, so they have years and years of experience. But yeah, if you want to bring us in just to help in certain areas, if it's coding, if it's credentialing, whatever it might be, we're here to help you guys. You know, we fix issues, we can train staff, and we just want to see you guys be financially successful. I think that was kind of the big overview of what we found. I'll turn it over to you guys if you guys have any questions for me, or Tish, if you want me to go in a little bit deeper.
No, I don't need anything deeper. What I do, you want to explain, we did the 0 to 90 and the 90, so we can, and what the options are and how far we can stretch it out, or the fact that we can condense it. We talked about that. It's in the report.
The timeline.
The timeline, yeah.
For doing that.
Yeah, so we have the strategic roadmap where we like to work in phases. So phase 1, we go all hands on board. We get as many claims refilled as we can. If there's any holes, we try to work all the holes and get stuff filled out. So we do fill preventable denials. We try to clean up the self-pay accounts in these first 90 days. We're going to get the providers enrolled that are not enrolled correctly. And then, you know, like I said, talked about the EKG and clinics, just making sure that it's set up correctly, the bill correctly. So that's like kind of phase 1. Phase 2 is kind of where we centralize workflows. We look at training more staff. We use more claim scrubbing technology. And then phase 3 is just sustainability, monitoring your KPIs, making sure your staff is accountable to their benchmarks. So that's kind of it. And we can kind of, when I talk to Tish as well, we can do kind of both at the same time. Like we can do work on the claims that we can get rebuilt. We can also start working on improving and process workflow at the same time as we're cleaning up as well. So it just kind of depends on how fast you guys want to move, what you guys want to focus in on as well.
Thank you so much.
Thanks, Patty.
Appreciate it.
You're welcome. Does anybody have any questions or? No?
Patty, I just have one question, or two, sort of. Where are you located, and do you use staff that's based out of the United States of America?
We are based out of San Diego, and all of our staff is in the state. So we have some in California, some in Florida, but none of them are out of the country. They're all people you can call up on your phone, you can get their numbers. Yeah, so none of my staff is out of the country.
Thank you for that.
You're welcome.
She's got one of those over
I think that's it, right? Does anybody have any other questions or anything?
Well, we can,
Okay, we'll go ahead. I'll be in touch with you tomorrow.
Sounds wonderful.
Okay.
Thank you so much for your time, everyone. Have a great evening.
Thank you, you too.
Bye-bye.
Bye-bye.
So are do we have, are we on to the quality?
yeah, because we can talk more about the details on the finance parts of it, because we're gonna have to be careful, because we have another vendor, we have to be careful of details. In fact, I have a non-disclosure on that one. Huh?
Are they gonna,
I couldn't get them to come tonight, so,
They weren't completed yet.
sorry. That was my wish.
okay, you're up, Jim.
So for my quality report piece, I wanted to talk about the CNA situation. So right now for our CNAs, we have 4 that are working failed either their knowledge test or their skill test, so they're not their temporary license anymore, so they're in that in-between phase of having to pass their state testing in order to get their permanent license. So we've got 4 of those. We've got 2 working with their temporary license right now. They will be testing, I think, here in the next month, I believe, to get their permanent license. Their temporary license good for 4 months, so they can work on that for 4 months. I have one that just passed her skill test the other day, so she got fully licensed yesterday. One is in clinical. She's had her first day today, and then she'll do the next 2 days next week. And I also had 2 new enrollments just yesterday and the day before, so that's good. But I did have to remove 2 from the class. They just weren't communicating back to me, so they weren't completing any of the assignments or anything like that, so I had to remove them from the class. So part of the piece with them failing their skills test or their knowledge test is we introduced aptitude testing, which is basically just an entry-level test to see how you test. Will you be able to take the CNA test and possibly pass it on your first go-around? And so I've also been telling them that we've been having difficulties with other CNAs passing their skills and their knowledge tests, so that they need to actually put forth some effort and study. If they have questions, they've got to come to me, because if they don't come to me, I don't know that they're struggling. We also did a CNA obligation form just saying that within 30 days of them applying for their license, they will get testing scheduled. I don't want to see them too far out, because then they may forget what they learned. I also created a reflection form if they do fail their test of why they think maybe they failed. Maybe they didn't study enough, so that just helps me meet them where they're at, and I can help them with what they might need. And then I also beefed up my expectations form to include that they will be in constant communication with me. I also had 3 board of nursing complaints that I had to take care of last week. So those are done. We're just waiting for me to come back on that, and I think Cassie will go into that a little bit more later. And then credentialing, we do have some credentialing tonight. I've got Dr. Meir, Dr. Graham, and Dr. Sue. They're Blue Sky Neurology, and then Dr. Doman's Dakota Radiology, and then Dr. McCarty, he's the clinic. Nothing of concern in any
Should, hopefully you're not discouraged about this stuff.
I was a little bit wondering how I could do better, but I think we are on a better track.
That sounds like it adds a lot of accountability.
Your plans are really thorough and helpful. And what is involved in a CNA in the testing? Do they have to go somewhere?
So they can do their knowledge test. They can either go somewhere if they want, or they can do it at home remotely proctored. So they just download Zoom on their phone, they set it up, and they have a proctor just watching them take their test. But they test them on, basic nursing skills, mental health issues, infection control, just anything that they might see over in the nursing home. So we did look at a report the other day to kind of drill down maybe where these students are getting the best score. And so I'm also going to try to include like a lecture piece where at some point during their knowledge piece they will have to come into me for, maybe a day, half a day or something where I lecture them on the high pieces that they need to know. And then we can continue on.
You guys also selected special mentors, right?
Yes.
So that was good.
Yep, we identified good preceptors over at the Manor that are gonna mirror good behavior. So, that's awesome. Yeah.
So it would be appropriate to give the board an update on the monitoring that's going on the transfers issue that we're doing.
TMS.
TMS transfer.
So I believe Tammy met with them a couple weeks ago, talked to them. We provided them with our transfer numbers, and they are in your everyone drive. The percentages of the EMS, the ground transfers that we have, they're actually surprisingly low of the transfers that they do take out of here.
The best way to know the world is to read your local paper, and I'm going to give you another hint, being a paper boy. When you get your local paper, like my mom used to do, put the front section away and go to the metro section. That's where all the great dirt is. So you read the metro section, and you will start to become so much smarter than the kids that are just academically debating, right? It'll be common sense and street smarts.
Really quick, last question. We got to welcome Secretary Nome.
So yeah, Kristi Noem was the next guest to take the stage there. But boy, again, I mean, none other than President Donald Trump is committed to a printed newspaper. I mean, as fan clubs go, I'll take that one in the whole modern political landscape. Donald Trump, Megyn Kelly, Steve Bannon, and Charlie Kirk, at least in Wyoming, I guess. Those are some pretty powerful names supporting printed newspapers.
And they are aiming more everyone drive. The percentages of the EMS ground transfers that we have are actually surprisingly low of the transfers that they do take out of here. So Tammy's going to be working with Shane a little bit closer on how we can get our transfers. It seems like maybe the crew here in town forgot or forget sometimes that they've got this new power bus that they can call in to help out. The power truck.
They had a special meeting with a group called Solution Technicians or something, and so there was a meeting that was with Gillette, ourselves, the county commissioners, or somebody from the county came to it, and we're trying to figure out a solution for it, because the real part we talk about is the transfers. 911 get handled, not always super timely, but they are handled. Of course, we have a big county, but that is the transfers that concern us the most, because those are the most lucrative for somebody who's really. So if I were an ambulance service, those are the calls I would love to have, because you make money on them. You don't tend to make money on the traumas. So we're trying to
So normally the EMS crew, they do a 24-hour shift. The power truck is a 12-hour shift, and it's kind of offset from the shift change because a lot of them, some of the transfers would happen at shift change, so they try to offset that shift change. So if we have a transfer, if it's close to that time, they bring that power bus in, and then, you know, it helps with staffing fatigue as well, because they only work the 12-hour shift, so they shouldn't be as exhausted as somebody that's been just working on a 24-hour shift. So kind of help with the fatigue.
Is it an actual vehicle, or is it just?
It's called a power truck, and I actually haven't seen it. I'm gonna guess it's a little bit stripped down ambulance. Yeah.
It might just be like a BLS truck, maybe.
So is it here in town?
No, I think it's home bases in Wright, I want to say.
Yep.
And they have to bring it,
So they have to bring it in?
they have to ship some crews over and then bring it. Maybe a drive the crew.
We've got we actually did some work to say that we would share staff with them if we have, because if we have a really critical patient, we'd like to get them out. So we did some policies so that we could share staff. We just have to work with Gillette about an MOU, and I know what that's going to do is, well, are you guys going to charge us for your staff, or what are you going to do? And I'm going to talk to Gillette first before I decide, because it's like maybe either we split it or something like that. I'm not as concerned, not that I shouldn't care at all, but I'm not as concerned about the cost of our nurses being in the back of the ambulance and getting somebody where they need to be as I am as getting them there. So, so.
That's like I said, I appreciate you guys' work on it. I mean, I know that's a big concern in the community, so.
Thank you. Well, Tammy's bulldog on it, so she's gonna get that taken care of.
Is there anything else? Any more questions for Tammy? So now, Shane, you're up next.
Current census of the nursing homes are 54. For July, we averaged 53. In July, we had 1 admission and 2 discharges. Currently, we have 5 referrals. those 4 of them though are Medicaid pending ones that are somewhere in there. So, yep, rating of the facility, we are 3 stars across the board on everything. Unfortunately, CMS has frozen the rates till October, and I was planning on us actually giving a 4-star here very soon, so.
Yeah, I know, I was bummed when I saw they suspended it.
Yeah, yep, so they're just doing system upgrades, so we're just gonna wait for that, so. Staffing, probably the biggest challenge, so. My own agency staff members, we actually canceled 2 contracts today, so that's great. Yes, so, came for those, it's good, so. We have 1 RM that started this month, 1 LP that started this month, 3 CNAs that have been hired for this month. We have 2 more CNAs hired, we're just waiting for their licenses to transfer, they have licenses in 2 different states, so that takes a little bit. Actually, we're going to update this. Another one just got a license today that they got hired, so staffing's looking better. And then on the accounts receivable side, we are down to 4 Medicaid pending. 2 of them have everything in the state, so hopefully we hear something very soon.
And we have 2 cases that we are sending to Allison that we just did today that are people that are in debt to us too much, and they didn't qualify for Medicaid, and the families haven't done anything with it, so we're just sending that to court. I mean, sending it, we'll see where we go, we may end up in court, so. Because unfortunately, it's a lot of money.
Any other questions for Shane?
I'm working really, really hard, so thank you.
Okay, so now we're on to Carrie. You want to do the finance committee report first, and then we'll get to
Yeah, Tish is gonna go over all the numbers with you, but I'm super duper excited to report that you have numbers, huge stacks of numbers, which is really wonderful, and we're really grateful that we're moving in the direction of getting some good, valid numbers. In Finance Committee, we spent a lot of time on Tuesday going over all of the departments, and we were finally able to do that on a department level, so it was really exciting and good. We would, as a Finance Committee, like to go through in great detail, probably at least 1, probably 2 more times, 2 more months worth of data until we can really get a handle on what's being reported and everything. And then I know we had said that we were going to present some more condensed, better able to understand reports to all of you in this committee, and I just ask that you give us a little bit of time to do that, because it's new, all the data that we're getting is new, and so we would like to understand it more ourselves, right, Ted? Didn't I explain it well?
Yes, I think you are. The only thing I would add to what you explained is these numbers will be readily available if there is a question and we want to drill down deeper in any one of the segments. They just may not be on a piece of paper, but they will be available to see if there's a question on something.
Right, right.
So it's not that the work's not going to be done, just like it's not done in this. It just...
But just to assure the board, we have real numbers now, and we're really excited about that. So we will be able to, as a board, make better financial decisions very, very soon. We did have a lot of discussion about accounts receivable as well. I, for one, I'm very distressed at our accounts receivable, and I have been for a long time, and I haven't been secret about that with all of you. But our staff worked too hard here. I mean, you just heard the reports of all the good things that we're doing here, and our staff work so hard.
And we as an organization need to get paid for that. And it is just not acceptable that we do all of this work and we can't get our billing straight in order to get paid for the work that we do. And it's also not acceptable to any of us that we can't get good, clean, accurate, timely bills out to patients. It's not fair to them, it's not fair to us. So we're working very hard on that. As you saw, we are looking at some outside companies that can help us with that, and we'll have many more discussions about that. Did I miss anything?
No, I think you explained because that's been real. For quite a while. Just talking here recently.
That's it from Finance Committee.
Okay. So, we changed things up a little bit. We tried to, the beginning of a new fiscal year always gives us opportunity to kind of tighten up and change things, not too drastically. So we ended up we did a new narrative. We did the utilization statistics. We loaded them up onto the SharePoint in July, then we loaded one up for June and July. So if you don't have the June and July one, I have copies. So first of all, we're going to go over the P&L, which is the P&L gives us a picture.
So is it in this piece right here? I mean, I have it in the thing.
Yes, but should be. Okay.
Did you put the P&L with it? Did you put the P&Ls with it?
Should have. Sorry, okay, sorry. Maybe it's one page down. I didn't put the packets. Yeah, okay, so, okay.
I found the balance sheet and then I got there.
Oh, yeah, so it should be the next one. It should look like this? Yeah. Okay, great.
The one with all the numbers.
It's the one with all the numbers that look really crowded. Do you have a packet?
I do.
Okay, thank you. All right, one of the first thing we're going to go over is we're going to look at total patient revenue. Our total patient revenue was 2.6 million. We budgeted 2.5 million. So we were over budget, which is a good thing. And then we have our contractual adjustments, which are reductions or our discounts that we agree to. So we had a total revenue deductions of $767,000. Versus a budgeted of $808,000. So it was slightly under, even though our bad debt was over budget, and we're working with revenue cycle to get a better grip and timeliness of turning over our accounts and turning them over in a set amount of time. That comes with working your claims in a timely manner. So basically we had the total revenue deductions, and we had other operating revenue. That is our retail pharmacies. And the retail pharmacy revenue, they were a little slow. It was less than budgeted. They're aware of that. So the revenue was $430,800. We budgeted $546,000. So they are a little under budget. So we have total net patient revenue of 2.29. Our budget was 2.28. So we were still over, even though we had a few missteps in some of our revenue. And then we have salaries. So salaries came in at 1.2 million. We had budgeted 1.4 million. The reason it is so low is because what's in there is the clinic director is not there, the new HR director is not there yet. So when they start and getting paid, those numbers will increase. Also, we did allow for CNAs, 11 CNAs when we budgeted. So that will, as they start working, we should see a correlation of reduction of travel and an increase in our salaries, which is where we want
the adjustment for all of them that we talked to you guys about for the CNAs. That adjustment was done.
All So then we have, so we're under budget. Benefits continues to plague us. Blue Cross Blue Shield bill was $298,000 for the month, which we don't have a lot of control over the amount that they bill us because we are self-funded. So when we get ready to start looking at benefits later on in the year, we are going to take a look at just a flat PPO type market share policy and see if it would actually work better for us, where it's a little more consistent all through the fiscal year, which would be very nice. Non-benefit expenses is under budget, and that's where travel resides, education resides. So in July, we don't really have a lot of that, but we have more travel, more education coming up as the months go down. So we've already seen the revenue, the reservations and things like that. They just haven't had the expense yet. So chargeable supplies, this is where we book our drugs, where we buy our drugs. So one of the things that the retail pharmacies did was they didn't buy a lot in June because of their inventories would have to be counted and recorded. So they made up for it in July, not realizing that they should have been purchasing consistently throughout both of the months. So talk to Aaron and Travis, and they're just going to be a little, it's better if they're more consistent, unless they're booking and buying for 2 months, then we do a prepaid, we split that expense. So it hits the financial reports evenly, which is what we want. We want consistent expenses and exemplary revenue. So we have, our total supplies were over budget. We spent $740,000, we only budgeted $593,000.
What's non-chargeable supplies, what falls under that?
Those are things like pens, office supplies to wash people, shampoo, tourniquet, anything that we can't bill for that is not recognized by CMS as a bona fide patient care item. Even though we put tourniquets on our patients, they don't consider that a chargeable supply. That's not something they're going to pay for. It's part of the room charge, basically. Yeah, they would do that. So we designate that out because we do charge, and we do then record all these for our cost reports, so we can get, it's like, if you get a flu vaccine clinic, they won't pay for it, but we can record it on our cost report, and we will get about 10 cents on the dollar reimbursement for it. So it is a way for us to get some additional reimbursement back that we were denied over the course of the year. Repairs and maintenance was only $8,000, we budgeted 10. That should be fairly consistent. When I talk to Ron, he doesn't anticipate, unless we have everything that we're doing, like we have some major repairs going on. Those are under capital, so they won't hit the P&L. They will hit the balance sheet under construction in progress until the entire project is completed, and then it will be moved to a building maintenance under fixed assets. So we have marketing and advertising. And so Charlotte and Kathy are working, they have a big project. Denise is helping with all of the advertising and the marketing. So we were slightly over our marketing budget. We didn't have a marketing budget per se before. It was just a lump sum. So it's a learning curve. This is going to be a learning curve as far as the marketing goes for us. So good marketing. I like marketing. So our hospital expenses were $29,000 versus a budgeted $38,000. So what we decided to do is we pay like our workers' comp and our malpractice insurance. We pay that quarterly. So we book it into a prepaid and expense it monthly. So you should see that be fairly consistent throughout the fiscal year. Depreciation, well, utilities were a little high. Not much we can do about that. Black Hills is tough to negotiate with. So we have our depreciation and amortization. We have budgeted $121 $8,000 a month. The reason we are so low is we haven't completed the project for the CT, nor for the Omnicell server upgrade. When those have been completed, they will move out of construction and process over to fixed assets. At that point, we will start depreciating their life value. So then we come to recruiting and credentialing. This is where we hide all of our travelers, fall up under there. So it rolls up under to credentialing and recruiting rather than broken out onto its own line. Now, we can break that out into its own line if that is a preference. I'm sure the finance committee will let me know. We have miscellaneous and other fees. We allowed $21,000 for that. We were only at $17,000. We are trying to make sure that all of our department managers know that we don't allow miscellaneous expenses anymore. It's got to fit into a category. It's a medical expense, it's an office expense. So that again is a learning curve. But we do have just some purchases that can be classified. So we can always bring those up if you're interested in that detail. I looked over it, it wasn't anything that was traumatic. So we did book $8,000 in audit fees. So we have, which is under budget. What did I say? 8. Oh, sorry. I'm sorry, I did fix that bill. It was 8, it is now 6. So we are maintaining our budget for our audit. They do anticipate that we will be able to stay under the budget because we internally did the majority of the work rather than last year where they did the large majority of the accounting. So that will be okay. But you can see we are still over on our operating expenses. We came in at 2.5. We budgeted 1.4. 2.4. Good Lord, I need more coffee. Yes, 2.4.
It's the travelers.
It's the travelers. It's the travelers. As we see a reduction in those travelers, we should see a reduction in our total expenses. Because what they're gonna get paid for salaries is going to be less than we pay them as a traveler. So even though we're bringing them into the part of our family here as our employees, they won't be getting paid a traveler rate, which covers their administration for the company that they work for. So we did receive $21,000 in grant revenue, and I did break that out if I could find it. We got $7,000 for dementia training. We got $11,000 for IT cybersecurity. It's on the front page now. Yep. Kim got $2,625.60 for MB Quick quality training. So that, and then we received $37,600 for the mill levy. We had meal income of $1,100. We had rent income of $2,300. We had interest income of $8,000. That $8,000 comes from our money market account. So because it's so high, we get a lot of interest on that. So that's where we are on that. So we did get, it shows on your P&L, it'll show the interest income. The interest expense, the $6,234 is what we pay on the bonds. So that will be, it will rotate a lot through the course from start to finish because it shifts from principal to interest during the course of the year, so you'll be able to see that shift. That will be, it will rotate a lot through the course from start to finish because it shifts from principal to interest during the course of the year, so you'll be able to see that shift as well. So the total of non-operating revenue was $64,000, which brought our net income to a net loss of $171,000. So I do want to say that for the first month, we did a good job.
We did a great job.
Other than the travelers. Other than the travelers, but I mean, department managers were very dedicated getting that revenue up. And so kudos to them. This is a first for the department managers in a long time.
Several departments were over, so.
Yeah, almost
Over, it starts more money in.
more money and well, they had more
They
money.
very well controlled their expenses, and they earned more money than we budgeted for them, so.
Yep.
The travelers are spectacular. We come back every day. I'm sure.
We need them. So we did, the balance sheet for those of you that don't know, probably everybody does, is the overall health of our facility. A P&L gives a snapshot within a specific time frame. A balance sheet gives us the overall health of the facility or of any other company. So we had increasing cash collections. We have, what that was we had poor collections in June that we collected in July. So we collected our normal amount in July with the addition of the back collection in June. So that's why we had more cash collections. Our accounts receivable increased by 1.1 days. Our gross days are 52.6. Our goal is 45 days, and that was confirmed with DZA, our auditors. That's about where we should be for our AR days. So I have some notes on what things that I wanted to bring to everybody's attention. During the month of July, Iridium reached out to us and requested our cost report funds back. So if you remember, the board allowed me to put that into our money market account as safekeeping. So it was a good thing that we did that. We had an additional $83,000 that we had to pay them, and that would have been the increase from the cost report when they requested it back. They request that all back. We can request another rate review when we file our corrected 2024 cost report, and we will do it again when we file our 2025 cost report. We can request rate reviews at that point. They'll go back in and we'll be able to, rather than wait for a whole year to get our increase, we will get it immediately. So that's what we're going to do. We anticipate being able to complete our 2025 cost report by the end of November. So it will put everybody back on track. The audit is the end of September where we'll start it. So we're going to be in a good enough position because we have the same company doing the audit and the cost report, different divisions of the same company. So they communicate back and forth. So the entire time that audit is going on, they're working on the cost report. So it saves us some time in the long run, and it allows us to get them recorded and filed more timely. Because we are so far behind, we want to make sure that we can get it recorded and filed with the government as quickly as possible. So that will put us back on track.
Okay, so will we be on schedule
On schedule.
if we get the 2025 one done in November?
It's due in November. We can get an extension until December.
Okay, we don't want an extension, we want to get it done.
Yeah.
And so when do you expect that revised or the
The
2024?
updated cost report, as soon as the audit, the 2024 audit is completed, we will go ahead and, so what I'm going to do is I'm going to send the audit to the state, the audited financials to the state. I talked to our representative at Myers and Stauffer. They are going to actually update our Medicaid cost report for us. And then Durbin, who did our 2024 cost report, that's part, we're not going to a different company for that one because we've already paid for that. So they're going to go ahead and file a corrected one, and they have it done just before we get ready to file our 2025 cost report. So they should go in quick succession. And then we'll be all caught up, and the state won't call me about where all my studies. So we did the AR reports that we normally do, and it basically shows what we talked about in the narrative in a little more. And I apologize for the poor quality. They're snapshots of a computer screen, and then they just are not really very clear, so I do apologize for that. So we can see that the AR days are still at 52.6. We have a breakdown. We have $926,000 worth of accounts that are over 61 days. That's, the older things get, the harder they are to collect. That's just the way it goes. So of that, the majority of it is self-pay accounts. We have reached out to a collection agency in Gillette to see what their pre-collect program is. And I don't have all that data, or I would have brought it to the finance committee meeting on Tuesday. So I should get that, and then they can go ahead and take a look at it. It's a way that will allow us to reach out and make contact with our self-pay. Phone calls, they'll help with setting up payment plans in accordance with our parameters. They will help set up and get people qualified for our financial assistance. So I know if they have a clinic account and they would have qualified for the sliding fee scale, they will help qualify them for that and then notify us as well. So we will, my concern is, and it's the concern of everybody really in the business offices, we are not actively working those self-pay accounts. It's very important for customer service that we maintain that connection with our patient base. That's one way we can do it. So that's something I'm really looking forward to getting. The rest of the information in here is a breakdown between hospital billing and professional component, which are all on the first 2 pages. They're all combined on the first 2 pages. They're broken out on the last set of pages. So, did anybody have any questions about our AR report? No questions? Okay. Do we want to go over the cash flow sheet? Did everybody pull their one that has a combination June and July for the cash flow sheet? So I colored on mine, so those were my talking points. So we had an increase in cash come in, and I already explained to you how that occurred. We do show down at the bottom, I'm sorry.
We're still getting that.
That's fine. At the bottom of the form, it looks like, well, it looks like this mess. It's this mess. So, what we've got is, one of the reasons our days increased is our daily expenses decreased. Even though we spent 1.6 million through accounts payable, the prior month, it was a lot more than that. So our daily expenses dropped down, which help us increase our daily cash on hand. On the bottom of the report, it does show any transfers that we have from our money market account. One was the cost report payback, and the other one was the purchase of the Bayer Flex injection system for the CT project. We are getting a refund on that. The original injector that Keisha ordered will not work in our room, so she is ordering another piece of equipment. It is actually less money, so we'll show the refund going back into the money market account and then the correct balance coming out. So you'll see that next month, and we'll put the notes on the bottom so we can keep everybody aware of what it is that we're doing. I wanted to kind of go over the statistics. Did everybody get a June, July statistics? Did you get? Okay, everybody got them. I originally did just the July, and it was a little disconcerting. It was hard to see a trend, so I went back and corrected it. So we can see where we were. We see an increase in total patient days.
Hold on. It looks like
It's this.
way high.
Oh, it's all there.
Okay, that's after.
That's what.
Exactly, checks, that there's one in the middle that's the long one.
Yeah, I have a 1 and then a 2-month one, and we put both of them in there. I have copies.
It's not,
No, you only have, here.
Here. No, 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 no. Here. Here you go, sir. Do you have one? There it is. It's not, it's deceptive looking. It's very hard to look at 1 month. And 1 month does not make a trend. So even though it's prior fiscal year, it gives us a sense of continuity with how we're reporting our statistics. And do you need a copy? I have several.
I've got one in here. Okay. So I remember looking at it yesterday.
Yeah, we looked at it on Tuesday, so, so everybody's on there, we can see for patient days that we had an increase from June.
The new store. This is the one-stop shop. We have a pharmacy. We have a bootlegger's liquor. The deli, the food that you can get at a lunchtime is so amazing. The coffee shop. Certain Friday mornings, there's 30 people sitting here in all these chairs. This is the hub for people to come and visit, have their coffee, have their donuts. It's amazing what this area has done. Totally amazing.
So everybody's on there, we can see for patient days that we had an increase from June. Our swing bed really increased. Yep, and they were even busier in August, this month. So we all got swing bed training through one of our flex grants, and they had a day-long seminar, and it was really very informative, and everybody seems to have really taken that to heart. So that's good for us. We like that. So we had an occupancy rate of 11, including swing bed, excluding the hospital, we have a 40% occupancy rate. So our average daily census, including the swing bed, was 4.8. That's like an all-time high, which is great. That's super news. So we have, we did have to keep our discharges. I'm required to, some of the reports that I have to fill out require that we report discharges from the hospital. So that is kind of a new one we started collecting last month. And then we have outpatient discharges. So we had 13 in observation. Anything other that doesn't qualify for observation would go under OP other. We didn't have any. We had 195 ER visits.
Which was down a little bit.
It was actually up a little bit.
No, was it up?
It was up by 10, sorry. 10 over June.
I think it was the revenue that was down.
Revenue was down because they have lower acuity.
So our credentialing thing.
And, well,
Yes.
the revenue would, it's just the cash that's gonna suffer on that one. So, our clinic days,
Just reminding me to take medicine.
your medication. Our clinic days, so Newcastle patient visits, we had 288. I'm going to be changing the word urgent care. We are not a licensed urgent care, it's a walk-in. So I wasn't sure if I had told everybody that last month, so I'm telling you this month that will now be reflected as Newcastle walk-in visits.
So the patient visits, not appointments, that's what.
Yes.
Yeah, it's a walk-in.
Yeah, and then if you're in urgent care or walk-in, you just sit there until they have an availability. You're willing to do that, which is fine. And then we have Upton patient visits, which were 56 in June and 47 in July.
What was it, 30 or something the month before?
The month before, yeah, it was way, way low. So we're seeing improvement, even if it's kind of up and down a little bit. Before we were seeing pretty consistent low numbers, low utilization. So this is an improvement for us. Trish is going to make sure that it stays that way. No pressure, however. So we did 2,400 lab procedures. We did 864 inpatient. We did 1,600 outpatient. And they always separate their venipunctures. I'm not sure why, because it's not
Because
clinical.
closed one outside lab, so they charge for the vena.
Okay. Boss knows.
The lab is on fire. We love that.
Yep. So radiology really hit it out of the park revenue-wise. All of the modalities did really well. So poor Keisha was out directing traffic the day we had finance committee. She was out in the parking lot getting all of the units in the back.
She was.
So she was doing a very good job. So we only saw 276 patients, which is actually 2 patients less, but we did more exams. We were down on x-ray, we were up on CT, we were down on MRIs, we were down on the ultrasounds, and down on the mammograms, but we're doing really well for our mammograms. Mammograms are historically very low utilization in rural areas, so that's not a bad number, even though it doesn't look spectacular. But the echoes have increased.
MRIs this month have increased. She
MRIs,
added a person, she begged him to come in an hour earlier.
Yep, and so they did, I think she said they had 18 scheduled. And then they always leave some open for a little bit of walk-in. So they're doing very well. And then we've got our therapies. Our physical therapies increased, which was great. Occupational therapy increased. They increased all the way across the board. Their speech therapy went up, along with their maintenance utilization for folks that come in and use it kind of agents.
How's the maintenance money working? It's
settled down. We had a small riot in the lobby. They couldn't understand, it's like, we tried different options. So what we did was we were billing them in the past, and it was the timing issue. They would come in, we would have already billed them for the month, then they get another bill for $10. It was chaotic at best. So then we kind of worked out a process where they could pay when they came in. So they pay when they're registered, and then they go in, and they couldn't understand why we changed that. And then when we explained it, they slowly got, oh yeah, well, that's a good idea. It costs money for us to bill and things like that. So it's leveled out to a dull roar now, and everybody seems to be doing rather well with it. So I would say that that's a win. And then we're not sending out nuisance bills.
Well, just for you guys that are newer to, every town hall that we had, we got a complaint about people being billed for maintenance. So I said, why are we billing for maintenance? So Tish looked into it, and that was what we came up with. So that everybody kind of just knows right from the start. It makes it more simple, and
Yeah, because they couldn't understand, well, I just paid, why did I get another bill when I got home? Well, it crossed in the mail, and even though it's easily explained, it's irritating when you just paid the bill, you go to the mailbox, you pull out another one, and it's like, I just paid this. Why didn't they include this? So it's a good customer service for us as well. So Manor days for resident days went up. It was 1,636 days. We have 898 Medicaid days. Does that include Medicaid pending? Okay, I wasn't sure, so I didn't want to, so that includes all of our patients that are pending Medicaid. And then we have private pay days, and then we have VA days. So they were up across all the way across the board. So we have 91% occupancy, including the Manor, which is good. Manor discharges, they didn't have any in June. You had 2 in June and none in July. So we did update that. Yes. I'm going to put the months on the second page because it's disconcerting. I'm losing track of where I'm at. So So we have dietary meals. We serve 6,000 meals. Yes, we serve 6,000 meals compared to 5,900 in the prior month. Laundry, they did a bang-up job. They did 600 pounds more of laundry in July than June. We had slightly more retail pharmacy scripts. We had a lot more hospital pharmacy scripts. And so, the hospital pharmacy, yeah, the hospital pharmacy for sure. And then we have our nursing pharmacy scripts. So they filled out 18,600 compared to 18,400 the prior month. So then we have our AP checklist, our check register. So first of all, it's bigger than it normally is. And the reason is you will see a lot, it looks like this. It should say check register. Should be one of the last pages. Looks like this. Okay. So one of the things you're going to notice if you looked at it was there's a lot of voided checks on there. So one of the things that we did was we were trying to work within the parameters of the software to get multiple invoices to show up on one check for the vendor, like Cardinal. Pages and pages of invoices show up on that check. So they read in there and it says compress. So when we hit compress, it printed and paid the entire accounts payable. So then we had to go in and void out all the checks we didn't mean to issue. So that's why there are so many voided checks for this month. But we did pay 1.6 million in the month. That does not include payroll. That is just vendor bills and reimbursements to some staff, mileage reimbursement. So does anybody have any questions? If you haven't come across any questions, you can also call me, shoot me an email. Thank you for your time. Thank you very much.
Thank you. Oh, you're welcome. Go on through that.
Should we take a break?
Yes, I think, let's see, where are we at? Yes, this is a good time to take a break. You have to whistle. Okay, so take a 5 to 10 minute break. If we're all back, we will get started a little bit before 10 minutes, but definitely in 10 minutes. Roll on to the